we still have witnesses we would like to talk to them about.
Okay, well, let's make our record. You know, I can only go on things. You have a 403 issue going on here, we can deal with it.
Okay, thank you, Judge.
It eventually becomes cumulative. Is it relevant? Is the probative value, is it outweighed by the prejudicial effect?
Well, Judge, and I would just remind you that if this was one instance, yeah, I would concede that point.
I'm well aware we have 14 counts.
And you know, so all of these witnesses are like brand new as to an issue. So it's not cumulative as to these cases, to the counts they're testifying about.
Judge, I thought that's why the court took the time out away from the jury, and the jury had to be waiting in the jury room while we resolve these issues. What's the point of taking time to resolve these issues if you can come back after the weekend and say, well,
okay,
I didn't agree to anything.
I understand what you're saying. Okay? It wasn't the reason I took the time out. Okay? So that aside, you know, we're just going to have to play it through, I guess. So I'll note everybody's objections, their comments. I'll let everybody prop the record, but I want to get this jury going.
We would have ask for a standing objection to any of these topics being broached, so that I'm not drawing extra attention to it already by the constant objections.
Well, I think everybody understands what the issue is, and I think the Court of Appeals has enough foundation to deal with it. We're just going to have to play it by ear. And let's see where the questions go.
Yes, sir.
Okay.
All rise.
You may be seated. Good morning, ladies and gentlemen of the jury. Just so the parties know, Mr. Petticoat was gone this morning because of a family issue. I had to look the jurors in, so I actually have to talk to a couple of them. Good mornings, that was about it. I didn't talk about the case, did I, guys?
No.
So, with that, Mr. Zion, call your next witness.
Thank you, Your Honor. The state of Ohio calls Jake Deemer to the stand.
Y'all have a good weekend? Y'all look pretty rested. How about you? That's different. I was yeah, well, Sunday night, I think I slept 10.5 hours. So when I got up, it was late afternoon. It's a good thing. Okay. You solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God.
Yes.
You're going to make yourself comfortable. You can lower your mask if you like. Okay, you got that aerial mic there in front of you. I need you to state your name for the record and spell it so that my court reporter can get your diction.
My name is Jacob Deemer. It's Jacob, last name Deemer.
Okay, can you guys hear him? Yes. Okay. You want a little volume? Little volume, okay?
Yes.
You can yell us. It's okay.
Yes.
Mr. Zion.
Thank you, sir. Can you please tell us, where did you grow up?
I grew up around Pittsburgh, Pennsylvania.
And what college did you go to?
I went to Capital University from 2012 to 2016.
What did you study at Capital University?
I got my bachelor's in science degree in nursing.
All right. Tell us about your training that you went through at Capital University to do what you to get that degree.
Yeah, so Capital, obviously you have your coursework. You study basic intro level stuff to nursing and healthcare, but then also you couple that with some clinical where you sort of have a residency, if you will, at various hospitals around Columbus. Respectfully, I enjoyed my time at Capitol. However, you really learn a lot on how to do your job on the job. So Capitol was more of getting your feet wet.
Well, tell us about your clinical experience while studying. What, if any, hospitals locally did you study at while at Capitol?
Yes, I did. My first clinical was at Mount Carmel East. I rotated through Riverside. I did OB, maternity infant at Riverside. I did community health, and then I also did a preceptorship experience, which is where they pair you and shadow you with a nurse. And I did that at Grant in their trauma bay.
All right. At some point, did you wish to do a preceptorship in the ICU while studying to be a nurse?
Yes.
And were you able to do that while studying to be a nurse?
No.
Okay. Did you want to work eventually in the ICU?
Yes.
All right. So what year did you graduate nursing school? The Capitol with a degree in, it's an MS, Master's of Science?
No, so the first one's a Bachelor's of Science in Nursing. It's a 4-year degree, so I graduated in 2016.
All right. And did you thereafter take a test, a board, to become a nurse licensed in practice in the state of Ohio?
Yes, it's a NCLEX RN.
Say that for the record reporter. Spell that out.
NCLEX, NCLEX-RN. It's our licensure examination.
And when did you take that in 2016?
A couple months after I graduated, so maybe I graduated in May, so maybe July, roughly.
Did you thereafter get a job somewhere?
I did.
Where did you get the job?
Mount Carmel West.
And what position did you apply for, and what position did you get?
I became an ICU registered nurse at Mount Carmel West.
Did you apply for, or were you assigned a particular shift as an ICU registered nurse at Mount Carmel West?
So I worked the night shift, sort of by choice, but also by need. On the night shift, there's tend to be less resources in the terms of people in-house, so it's a little bit slower for new nurses, so you can kind of focus on your patients, but then also there's less distractions, and you get paid a little bit more, and I wanted to make more money.
Makes sense. Brand new. So this is your first job as a nurse. In when month you took your test, and you estimate July of 16. When are you starting your job at Mount Carmel?
Maybe September. Shortly thereafter, it was contingent. My job beginning was contingent on me passing that board examination. So the onboarding process started shortly after I passed. The exact month escapes me anymore.
Okay. Tell the jury about your onboarding process with Mount Carmel. Was there an orientation period? Did you work other shifts, etc.?
So yeah, there was technically an orientation period. It consisted of shadowing other nurses. Basically, it was should have been, in theory, a methodical way to introduce concepts and how to do your job to a new nurse, specifically any nurse, but also a new grad orientation. You would primarily follow around a nurse on the day shift, and then on the night shift, although I did do some days. But it's important, I guess, that Mount Carmel recognized the preceptorship experience as everybody being one nurse. So since I really had a minimal understanding of having never worked in a hospital, they would pair me with an experienced nurse, and I was basically tethered to that nurse. So anything that I did, they would sign off on, or anything that she did or he did, I would learn from that. So although two licensed RNs, we were considered one entity for the patient.
You said in theory it should have been a methodical introduction as to everything you would need to know. Did you find that to be what actually occurred during your orientation period?
No.
Explain that, please.
So there's a couple things. The first is there's always a nursing shortage. However, I was actually approached, I believe it was a 10 to 12 week orientation. I was approached, I believe, after week 8 by my manager, and the manager basically asked me to come off orientation early, and I expressed some concern about that, but she said that she would give me easier assignments, one patient, but basically my orientation was cut short to help staffing issues.
All right.
And being that Mount Carmel West is a mixed ICU, meaning that you can see medical patients, surgical patients, trauma patients, etc., it's not possible to see every type of patient in 8 or even 10 weeks. So there was something left to be desired for the orientation process.
So talk about how you felt experience-wise when you started. So if you started in September of 16, you passed your test and you're doing this orientation. Are we now into October, November, and you're on your own, basically?
Yeah.
All right. Talk about how comfortable you felt with the level of experience and training you had when you first started in the ICU on your own after 8 weeks of this orientation.
Yeah, I think it's relative. If there was a patient who had orders to leave the floor, I was comfortable with that. Basically very stable patients I was comfortable with, but there always was a little bit of apprehension. But I knew that I could go to my coworkers and ask for help. But I told them in advance in the huddles that I might be asking a lot of questions.
Okay. Talk about your understanding of the level of experience of your coworkers in general in the ICU back when you started.
So the charge nurses tended to be more experienced. Several come to mind that had 10, 15 plus years of experience. I would say most of the people were 5 years or less were working on that unit, but there were nurses that had tons of years of experience, but there were far more newer nurses than there were, 30-year veterans or something like that.
All right. And when you say newer, could you estimate, in your mind, your understanding, when you say newer, is that 5 years or less, or even less than that?
For me, I felt comfortable, really comfortable, and felt like I could teach other people at about 1.5 years. So I would say, when I say newer, I would say like between 1 and 3 years of experience.
All right. Did you have aspirations to continue in your education and seek a higher level of nursing certification when you started on this journey, started working at the ICU in 2016?
Yes.
What is that aspiration that you had?
To seek a career in nurse anesthesia. It's called a Certified Registered Nurse Anesthetist, or a CRNA. That was my goal from a very young age.
And would that require you to gain experience and then go and get more schooling, more education?
Yes.
All right. So this is something you had in mind when you started in 2016?
Correct.
All right. So tell us about, once you were past orientation, did you work exclusively on the night shift then?
Yes.
And tell us about what doctors you would work with on the night shift in the ICU at Mount Carmel West.
There were 2 doctors, Dr. Hagris and Dr. Husel.
All right. And did they seem to split the ICU, their time between the 2 of them evenly?
Yes.
All right. In your experience, did you find that you were working more with one of those 2 particular doctors?
It's hard to say. I would say maybe 60-40, but it depends. What I can say is I never put my work shift to line up with any of the doctors. It was organic when I worked. So I worked with them. Some days I would work with Dr. Husel 3 in a row, and then I wouldn't see him for 2 weeks. Other days I'd work with Dr. Hagris. So I can't say. Maybe 50-50.
Okay. Do you recall at a previous hearing saying that you, for whatever reasons, like organic you've just described, you would tend to, in your mind you had worked more with Dr. Husel?
Yeah, I remember saying that. I guess like if you're asking me to put a percentage on it, I can't. So, I mean, maybe shortly when I was asked that question, I don't know. I don't know. I would say that Dr. Husel seemed to work more shifts than Dr. Hagris. That's what I can say.
Okay. On a personal and or professional level, did you have a closer relationship with one of those two doctors?
Yes.
And which two of those doctors did you have a closer professional and personal relationship with?
Both, but number one was Dr. Husel.
And can you describe what, if anything, in your mind, attracted you to, in a professional sense, Dr. Husel?
Yes. His first and foremost, when I was orienting on the day shift, it was common knowledge, or at least it appeared to be common knowledge, that there was a doctor on the night shift who was very good, knew his stuff, highly educated, highly trained, and he would be a very good resource to learn, especially being new. Second, he was in anesthesia, and I had aspirations to go to anesthesia school, so I thought it would be, so here's a highly accomplished professional with training at the Cleveland Clinic who is doing the thing that I want to be doing, or something similar, and he's apparently very good. I should probably figure out why he thinks the way he thinks and learn how he does the things that he does, because it's led him to a great deal of success. So I like to copy people who have walked the path before me, because usually they're on to something.
Tell us about your understanding of the reputation of the Cleveland Clinic. You mentioned that by name, that he was trained as an anesthesiologist at the Cleveland Clinic.
Yeah, I can speak to it. I've actually trained there as well. It has a reputation for being a place where people who are very sick go. There aren't many hospital systems around here that are better than the Cleveland Clinic. In fact, people come from around the world to go there. So that's a pretty highly prestigious institution.
And this was something known to you and to others regarding Dr. Husel's background?
You mean where he trained? Mm-hmm. Yeah.
Okay. Were you aware of any awards that he had won previous to your employment?
I'm not sure previous to the employment, but I did know, and I came to know at some point, that he was voted, I believe it was Mount Carmel Physician of the Year.
And are you aware if this was something that was, that award was nurse-driven? This was something that the nurses would vote on to?
No.
Okay.
I didn't know how they came to that.
All right. What that was like, just to lay a foundation for your relationship with him.
I'm not sure if I remember the first time I met him.
All right. What's the first interaction that you do recall?
Yeah, I remember he came up to me. It was a slower night for me being new, and he pulled me into my patient's room, and he said, hey, this patient's on a ventilator. If I want to control ventilation or CO2, what numbers would I manipulate on this ventilator? And I missed the question. I had no idea, to be honest. And he educated me. And I, although respected, I always research for myself, so I had gone home later that night. I bought books to study on my own time, and I basically read about the things that he said, and it turned out to be true. So I just remember being educated about something.
But on his own, he came to you, took you aside, and took this time out of his schedule to help you.
Yeah, he did that with everybody.
All right. Would you ever talk to him about anything that wasn't work-related? Did you ever, did you feel you had a relationship with him otherwise?
Yes.
Tell us about that.
Him and I have mutual interests in fitness, so we would talk about lifting. We would talk about basketball. We would talk about the game the night before. We would talk about the Twilight Zone episodes. He was very approachable, but it was in a, well, he was very approachable.
All right. Did you two ever have socialized outside of work?
To my knowledge, no. We had talked a couple times, but those things were just talk.
Did you consider him a mentor?
Yes.
Did you describe his professional relationship being around him as more of an extended sort of preceptorship?
100%, yes.
And in fact, a preceptorship that,
Objection, leading.
Rephrase.
how would you describe this extended sort of, did you receive this type of extended sort of preceptorship in college?
I'm not sure I understand.
Did you receive this type of training that he was giving you in college?
No. In my experience, there's not many nurses who, ICU is such a wasn't likely to encounter any of these concepts in a trauma bay at Grant.
Okay. So what you're learning about the ICU and how it functioned is from your professional relationship, this mentorship with Dr. Husel.
Not mutually exclusive, but yes, he is part of that. There's other nurses, other doctors, even respiratory therapists. They're all helping to sort of educate me. But when it comes to educating, he was the only guy who would come up to you and be like, hey, if you have 5 minutes, name anything in this ICU and let's talk about it. I've seen him do that with respiratory therapists as well, and techs, people going to nursing school.
Did Dr. Husel ever write you a letter of recommendation?
Yes,
What did he write you a letter of recommendation for?
an application to get into anesthesia school.
All right.
I also received a letter from Dr. Hagris as well.
Okay. All right, let's talk about your training and knowledge at the time about
Yeah.
narcotics and benzodiazepines. Let's start about the extent of the training you received at Capital University, either in the classroom and or on the job regarding narcotics and benzodiazepines.
Very little. At Capital, we took one pharmacology class. I believe it ran for the duration of my junior year. Excuse me. And what it encompassed was basically talking about the group of medications and not actually discussing specifics about medications. So she would say narcotics, drugs you may encounter could be Dilaudid, morphine, fentanyl, but we never actually broke down the differences between the two. It was like you basically covered one group of medications twice a week, and then you moved on to the next one. So very little to answer your question.
Did you recall at a previous hearing describing it as almost none?
Yeah, I would say that's pretty much almost none.
Okay. So walking into the ICU in the fall of 2016, you have almost none as far as training in the use and application of narcotic pain medication and benzodiazepines.
I had given some, in my clinicals, but if you're I was unable to break it down on a pharmacological level as to how they worked.
Are you familiar with package inserts for these drugs?
I am.
And can you tell the ladies and gentlemen of the jury what a package insert is for these drugs in general?
Yeah, in general, a package insert is basically a piece of paper or a document that's included inside of the container that the meds are shipped in. It carries with it details and information about the drug. For example, Tylenol would have a package insert, so when the hospital orders a bulk order of Tylenol, there's a package insert and it would say important considerations to consider. It would list anything that you need to be aware of, and it would list a myriad of side effects and things like that. So it was, if you didn't know anything about the drug, you could read that and kind of get a sense of what it was for and how it worked.
Does fentanyl have a package insert?
It should, yes.
And were you aware of it back then in 2016, 17, 18, those years? Had you read the package insert for fentanyl?
No.
Okay. What about benzodiazepines such as midazolam and or Ativan? Do they have package inserts?
Yes.
And were you familiar or had you read the package inserts for those benzodiazepines, midazolam and or Ativan?
I'm not sure.
Okay. Was your knowledge back then that they would have recommended dosages? Like you said, for acetaminophen, I think you said it had like a recommended dosage?
I don't think I said that.
Oh, okay, I'm sorry. Well, were you aware of whether, in general, package inserts have a recommended dosage for their use?
I think it depends, but back then I would not have known that.
Okay. Talk about the training you received regarding policies and procedures of Mount Carmel during your orientation and or afterwards.
So similar to my main orientation, it was incumbent upon the elder nurse who was training you to basically teach you where to go and where to find the policies. So it really depended on if the nurse you were learning from even knew where to find them. They were notoriously difficult to find. So there's the internet. Mount Carmel has an intranet, so it's their own like in-house internet. And you had to click, in my opinion, it was difficult to locate those policies and procedures. So they were not readily a part of my orientation process. And to be quite honest, I'm not sure. It would have taken a considerable amount of focus to figure out where to find them.
Were you ever made aware of any policies or procedures or order sets that were in the Mount Carmel policies and procedures for palliative extubations in 2016 to 2018?
I'm not sure.
Okay. At that time, were you aware of Mount Carmel's medication administration and self-administration guidelines procedures?
Is that the same thing as Lexicomp?
Lexicomp is part of that, yeah.
I was aware of Lexicomp.
Were you aware whether or not doses could be adjusted outside of those guidelines?
Yeah.
Are you aware of what needed to be done if those dosages were administered outside of the guidelines in that policy and procedure?
Can you be more specific?
Well, under what circumstances, if you're aware, could dosages of medicines be administered outside the guidelines for fentanyl?
Objection, foundation.
I'll permit the question.
At the time,
At the time.
I believe so, yes. And some of those things that would require them to be adjusted could be opioid tolerance, weight, age, any sort of factor that makes us different. I believe one of them is palliative care.
Were you aware of whether or not you needed to go outside of those guidelines? You would need literature, some sort of either learned article and or...
Objection.
I'll let him finish the question.
Sure.
Were you aware that one of those guideline deviation requirements was literature that needed to be cited to go outside those guidelines?
Aside from being leading, it's misleading too.
Okay, wow. We're not doing closing argument. Let's relax.
I understand. Argumentative, and it does not apply to palliative withdrawal situations.
Okay. As the leading sustained. Rephrase.
Were you aware of what, if any, awareness did you have of literature requirements to go outside the guidelines?
I wasn't aware that I have to provide, I wouldn't even know who to give an article to. No, I was unaware.
What, if anything, were you aware of regarding special approval absent that literature from someone higher up in the chain of command?
Objection, asked and answered.
I don't think so. I'll permit it. Do you understand the question?
A little bit, no.
Absent literature
Okay.
that would support going outside the guidelines, were you aware of any requirement to get special approval from people higher up in your chain of command?
I would say that the people in my chain of command were involved in those practices. So I didn't seek any higher level charge nurse approval or something like that, because the charge nurses are the ones who trained me, and most are involved in this. So, no.
So you weren't aware of that special, of absent literature having to go off the chain of command?
Okay, overruled.
Correct.
He's just clearing up an issue. Go ahead.
Yeah.
All right. So to summarize and for transition, you received almost no training in...
Objection.
Well, I'll let him finish the question there. Go ahead.
For transition and for summary, as we go into the next topic, you received almost no training in college about the use of opioids and benzodiazepines beyond what you described. Is that correct?
Yeah.
You received no training about the use of benzodiazepines and narcotic medication during the preceptorship, the 8-week preceptorship you had, besides what you've described as being present when they were administered.
Asked and answered.
Well, he's in transition. I'll permit it.
Yes, I mean, I've given those medications to patients, but my understanding of them was limited.
And because of the difficulties in using the intranet,
Yes.
you had almost no knowledge or training regarding Mount Carmel's policies and procedures for use of those medications.
They were difficult
Permit
to,
it. It's transitional.
they were difficult.
Question, then we're moving on to the particulars of this case, Your Honor. And you've testified at a previous hearing that almost everything you knew in your first year of practice came from Dr. Husel.
Objection. This states the evidence, and this is
Okay.
the third transitional question.
Wow. There is no count, but that's beside the point. I'll permit the question.
Ask it again, please.
Almost everything you learned in your first year of practice at Mount Carmel was taught to you by Dr. Husel.
No, that wasn't the question. You previously testified to that. Is that correct?
If that's what I said, that's what I said.
Okay. So let's talk about December 5th, 2017.
Okay.
Do you recall a patient by the name of Danny Millett?
Yes.
All right. Looking back in your mind's eye, and you've had a chance to review the medical records, right?
Yes.
With that in your mind and looking back also, I want your independent recollection.
Okay.
Tell us about the first time you became aware of Danny Millett at Mount Carmel in December of 2017.
I was coming to work and I was responsible to take care of him.
All right. Describe his age, his condition, what you remember about him as you got to work, and what you did next.
So it was reported to me, he was an older guy, I believe he was in his 70s roughly. He had an extensive history of peripheral vascular disease, diabetes.
I'm
Yes.
going to stop you there. What is peripheral vascular disease? Your understanding of that back in 2007?
Objection. Is the counsel asking the jury this question?
Yeah, well, let's stay over here, but I'll permit the question.
You're asking me what my understanding back in 2017 was
Of peripheral artery disease.
of peripheral vascular
Vascular
disease?
disease, yes, thank you.
It's similar to peripheral arterial disease. So basically, I would have known this at the time as well, because of underlying factors, sometimes genetics, sometimes smoking, sometimes diabetes, all of which this gentleman did. It would cause your vessels in your hands and your legs and your body, everywhere in between, to become I'll say rigid, less pliable, so it's not able to adapt accordingly, and it can lead to issues if you think of a pipe, and I'm trying to get water through the pipe to an area. I'm trying to get blood from my heart to my foot, for example. If there's a kink in the pipe somewhere, or the pipe is smaller, or it's occluded or clotted, you're not going to get water to the end goal. So peripheral vascular disease and peripheral arterial disease would be the equivalent of not being able to get blood to certain areas of the body. And without blood and oxygen, importantly, to those areas of the body, you can have very bad issues.
Peripheral means like the in parts of your body, right? Is that what?
No.
No. Okay.
Like it could be it could be systemic. I don't know why it's called peripheral, but there's, peripheral's relative.
Okay. Do you recall whether or not Mr. Millett had any recent amputations?
He did have an amputation of a toe,
Okay.
secondary to those things that I described: diabetes, smoking, peripheral vascular disease. But he also additionally had a procedure, I believe it was a bypass graft. So that's a little bit bigger of an issue. So when you're dealing with bypassing vessels, you're actually bypassing bigger vessels in the body to try to reestablish or maneuver around clotted or bad areas of vasculature.
Do you recall, you said you recall him being in his 70s. Do you recall what his height and weight was?
No.
Is there anything I could show you which would help refresh your recollection as to his height and weight?
Sure. Yes.
Would the medical records help you establish his
Height and weight?
height and weight?
Yeah. Yes.
It's my understanding the records are stipulated.
The records are stipulated, Your Honor.
Why don't you just ask them if the question then?
Okay. If the records indicate that he was 5 foot 8 inches and 140 pounds, does that help? Does that sound about right in your mind's eye looking back on it?
Yes.
Okay. And he has had this toe amputated. He's had a vascular bypass done on his leg. Were all of these things been made known to you as you come into work that day?
Yes.
Okay. And you're working the night shift in the ICU, right?
Yes.
All right. So looking back in your mind's eye, it's December of 2017. You walk in. We've heard about this handoff or huddle that you have with the previous care team.
Yeah, that's correct. The day shift nurse would give me report. This is the gentleman, this is why we're here and how we got to this point and what we're doing.
Okay. And did you do that with Mr. Millett?
Yes.
All right. And so in our timeline, this is about a year into your work.
Yeah, roughly, yes.
You've been working at Mount Carmel in the night shift for about a year, maybe a little more than it.
Correct.
Okay. And do you recall who the doctor was on shift that night?
It would be Dr. Husel.
All right. So what happens? What happens next? You walk into his room, I'm assuming, at some point?
Yeah, I walked into the room.
Tell the jury about the care. What are you doing? What are you looking at?
So I'm looking at everything. Obviously, I get in report that this gentleman is very sick. So he had this procedure, and he's back with complications secondary to some procedures. He has septic shock. So septic shock is a pretty bad bloodstream infection that can lead to some very bad outcomes. So I get in report that he's on vasopressors, Levophed, or another name is norepinephrine. And to me, that's significant right there. And I believe he's intubated at the time as well. So in my mind, at least the way that I process information, I hear about septic shock, which is potentially fatal. I hear about him requiring ventilatory support, so his lungs have failed. His kidney function has failed, as evidenced by his lab work. He's requiring adrenaline, basically. So like I always say, that when I think of vasopressors, that is the stuff that pumps through a mother's veins when she pulls cars off kids. That's adrenaline. This is noradrenaline. We're giving that in an IV, and I believe he had needed CPR at some point as well. So he's very, very sick. So yes, I enter the room knowing all of this. I check my drips. I check the patient. I see where we're at.
What happens next?
At some point throughout the stay, after my initial assessment, I made it part of my regular practice that when I have a super sick patient like that, I'm trying to check something every 10 minutes, every 15 minutes. I'm at least around the room, if not in the room at all times. So for this gentleman in particular, something that stands out is upon doing my assessment, part of it is to check pulses in the extremities. You check them in the neck, in the groin, in the feet, in the hands, etc. He lost pulses in his left limb, in his left lower limb. So that is significant to me because 1 minute he's, I'm gonna say relatively fine given all those things I described, and then 1 minute later we have this drastic change to where quite literally, going back to my example of trying to get the water somewhere or the blood somewhere, his leg will begin to rot now. So my initial, it's going without oxygen, the whole leg. So my initial reaction is to call the doctor. So I called Dr. Husel. Dr. Husel comes to the bedside. We assess the leg. We both cannot appreciate the presence of pulses. So we put what's called a bear hugger, which is a glorified name for a warmer, on the patient's leg to try to bring warmth, which brings heat, which brings blood to the area. And I believe a vascular surgery consult was placed. So this is indicating to me that while we were sick when I came in, we are beginning to get worse. We are starting to lose perfusion to limbs of the body.
All right, so you say you checked the left lower limb, so is the bottom part of his leg here?
Yeah, yes. The knee and below, yeah.
All right, so are you just doing it with your fingers, you do it with the stethoscope?
You could do it, so the way that I do it, I start by trying to touch them. I try to palpate them. Failure to do that, usually I like to think I'm pretty good at that. I was unable to. Sometimes the patient is swollen and you can't. So then my next intervention was to grab a Doppler. So a Doppler is basically like an ultrasound that you could listen to a baby's heartbeat with. You basically put gel and you just move this little dial around until you hear something.
How long is his left lower leg there?
Yes.
And you can't hear anything?
Which is pretty much indicative that perfusion has been compromised.
Okay.
Okay, hold on. When you let him get his question out, a couple
sorry.
times you want to get out there, get that answer out there, we'll get to it.
Yes, sir.
But this poor lady's taking it down here, and we don't want her fingers to go up in smoke, so.
Yes, sir.
Mr. Zion?
Sorry.
So you said Dr. Husel came in, confirmed what you found. The vascular consult was done. What happens next?
It gets pretty vague from there, to be honest.
All right. Does this situation improve in your mind's eye as you look back on this, or does this situation continue to deteriorate as you look back on this?
As I look back, in my opinion, it continues to deteriorate. When you have a drastic change like that, it's important to let family know. It's important to keep them in the loop so they can make informed decisions about the goals of care. And I believe at some point shortly after that,
What about his condition? As you look back, having reviewed the medical records, he's intubated, you've described his medical condition. What about his awareness? Do you recall if he was awake, if he's talking to people? Because you can be awake and ventilate, right?
you can.
Yeah. Was he awake?
No.
What about his level of consciousness that you recall, and based on the medical records?
He was fairly, I'm trying to use the right word. Let me think. He was out of it. That's what I'm going to say.
Okay. So you can't talk to him about what he wants next, right?
Correct.
So you talk to the family.
Yes. The primary decision maker, which is usually always family.
Okay. So did you participate in this conversation with the family?
Yes.
All right. Was Dr. Husel present, and did Dr. Husel, in your memory, participate in this discussion?
Always. It was customary in my practice, anytime that I was updating family with something significant, the doctor had to be present at the bedside.
Okay. Did you bring the family into bedside, or did you meet with them in a family room?
That I don't remember.
Okay.
In my practice, usually at the bedside, but I can't say specifically for this.
All right. What, if anything, do you remember about what you said to the family regarding Mr. Millett's condition and prognosis?
Yeah, I mean, I basically told them the same thing I told you. I would have said, we're having changes in his care here. We're giving this medication called adrenaline. It had not been explained that way to them before. I told them about this newfound change in his status, what we were trying to do to remedy that, and then I think we referenced some lab work. And I was a part of that, like pulling up on the computer and things of that nature.
Are you aware that in the medical records, the family had already agreed that afternoon to what's called a DNR-CCA?
Yeah, correct.
And what, in your mind, in your understanding back in 2017, DNR-CCA meant?
Yeah, so DNR-CCA, you have a full code, which is do all heroic measures, CPR, life support, intubation, all those things. Then you have a DNR-CCA, which means do everything that you can up until the point that the patient dies. And then if they do die, do nothing. Let that be the end. And then you have a DNR-CC. DNR-CC would be removal of heroic measures and allow sort of a natural passing without artificial means of life support. So he was a DNR-CCA, meaning that if he would lose pulses and die again, we would not implement life-saving interventions from that point to bring him back.
So what happened after this family meeting with you, Dr. Husel, and the representatives from the family there?
They agreed to change the code status to DNR-CC. So it was told to us, it was told to me that, passing naturally, pain-free, comfortable with the family at the bedside and not having tubes shoved in every body orifice was what the family wanted.
Okay. Do you recall what time of the shift this was for you that this decision was made?
I don't.
But working 7 to 7, this would have been in the evening hours or morning?
I mean, that
hours?
would be my normal hours, so that I don't really think of it like that.
Okay.
It's a 24-hour job.
Sure. But this is happening during the night shift at some point.
The change in care is correct.
All right. So what happens next after the family agrees to a DNR-CC?
Well, we talk a little bit about what that process is going to be like. It is discussed that, we're going to give pain medication. We're going to give medication to help promote comfort and only comfort. And we are going to remove and turn off these things that were keeping the patient alive. We discussed how it was impossible to determine how long, because most of the time people ask how long until, and it's, we say we don't know, we're turning off these medications, but we're going to give him pain medication to help make sure he's comfortable. We actually discussed like all of the stuff that we were going to do.
Did you talk to them about agonal breathing or the secretions that could build in his throat and what that meant as far as his discomfort and or anxiety and or pain?
Yes. We particularly the ones that I focused on was the rattling, secretions, vomiting, turning different colors. Sometimes you say agonal breathing, I think paradoxical breathing, meaning that when we breathe, your belly and your lungs tend to expand. Well, there's chances that one can go out and the other sucks in, so they work against each other. I've seen it, and it's it appears to be very uncomfortable.
So you prepare them for that. What did your training and experience tell you in 2017 about if that was actually painful or uncomfortable for the patient going through those things?
I don't think, personally, respectfully, I don't think any amount of education or training could prepare you for seeing something like that. So all training kind of goes out the window when you see somebody kind of like that. So I don't really have, I'm not sure what you're asking me.
Did you have any training regarding whether or not agonal breathing and or the secretions in the throat, it's also been called the death rattle, I
Yeah.
think they're called that, whether or not that was actually, I mean, disturbing for the family to watch, and you, apparently.
Yes.
What about, did you have any training regarding whether or not that was actually painful for the patient and or anxiety-inducing for the patient?
Specifically, secretions in the throat, and you say agonal breathing.
Agonal, paradoxal breathing, guppy breathing, all that?
I'm not sure if I ever read anything that said they were or were not painful.
Okay. Did you tell them the doses of pain medication? Did you get that specific? And the types? You said pain medication. Did you tell them the type of things you were going to get?
No, we didn't tell them the specific name of the pain meds that we were going to use. We just talked about that we're going to use a sedative and pain medication to promote comfort. And we talked about, we never discussed like, hey, we're going to give this much or something like that. But we said that we were going to give him an appropriate amount to make him comfortable so he could pass naturally with dignity.
Okay. As part of your review of Mr. Millett's chart and
Yeah.
part of your care earlier that evening, had you reviewed the previous pain medications and or benzodiazepines that he had received through the course of his hospital stay?
I knew that this gentleman, because in Mount Carmel system, you have, I'm trying to think what it's called. You would have had access to the previous hospital stay that he had when he had the surgery. And I knew that he got pain medication during then when he was shortly discharged. But I don't remember what I read about his pain medication up until that point. I can't remember.
All right, you're talking about his previous, when he had his toe amputated and the vascular bypass. That was a previous hospital stay.
It was, and you have access to those records as well.
Right.
And I would attempt to make it a point to read a little bit about that, only because that's why we're back again.
Okay. So he had not, during this particular hospital stay, had that pain medication, but in the from
Periphery.
December 5th, near that date, that had all happened to him, and then he went and came back. Is that what you're saying?
I believe so.
Okay. And you would have reviewed that?
Yeah. I would have particularly looked at like the OR records because of my interest in anesthesia, but also like, you know, if somebody is presenting back for an issue, you probably should go look at what the start to that issue was.
Okay. For this particular hospital stay, which, if the records say began on December 5th and ended on December 5th, had you had a chance to look at the medical records for that day he was in the hospital when he had come back?
I'm not sure. Wait, are you talking about the ones previous to that?
No, I'm talking about...
Oh, that day?
That day, because he was just there for a day, right?
Yeah, I'm not sure, only because he was pretty busy. I was doing something at least every 10 to 15 minutes, so I'm not sure. Can't answer that.
All right. Were you aware that he had only come to the ER on Tylenol?
Yes.
Okay. And that the only other pain medication that had been ordered for him was 2 milligrams of hydromorphine and 1 milligram of midazolam at 2139. Does that sound right?
Yes.
Oh, you know what? I don't know.
It-
I don't know if that's right, actually. I'm
Yeah,
trying to read my
can we
notes.
look? Is there any way you can bring it up
Yeah.
and we could just...
Let's
get it
talk
down?
about Danny Millett's, if we may. Is that me? While I'm looking that up, did you assess his RAS score?
Yes.
what do you recall about his RAS score? And just for the jury to remind them, what is RAS and how is it evaluated?
It's called a Richmond agitation score, maybe sedation scale or something like that. It's a measure of, it's one of the ways to measure somebody's demeanor. Yeah, and seeing as though he was kind of out of it, his RAS score that I scored him at was, I believe it was a -4 is what I gave him.
So if 1 or 0 is conscious and alert, and if you go to the positive, that's when people are getting angry and agitated,
Yes,
and then it goes backwards to -5,
I believe so, yes.
completely comatose, you rated him at a -4?
I think so, yes.
I apologize about the earlier medications.
Okay.
Were you aware that the only previous pain medications he had received during that, I mean, he was just there for the day, but he came in on Tylenol?
Yeah,
Okay. So, looking back in your mind and based on your review of the medical records, what was what, if any, order was given to you by Dr. Husel regarding pain medications to be given to Mr. Millett for purposes of this palliative extubation?
yeah, I received a verbal order for fentanyl and Versed, and I believe there was a Dilaudid attached to that as well. But I received that verbally from Dr. Husel.
What amount did you verbally receive an order for the fentanyl?
1,000 micrograms.
What amount did you receive a verbal order for the midazolam?
I know I looked at it. I don't want to say the incorrect number.
Sure.
Is it?
Showing you what I marked for identification purposes. And Judge, instead of going into since they're all coming in together, I'm just going to refer to these as States Exhibit 4, the medical administration records. Who's doing it? This would be the medication. I was just going to show them that on ours. That's just what I pulled out. Can I approach the witness, Your Honor?
You may.
Showing you the joint exhibit for medical records obtaining Millett, page entitled Medication Administration Record.
Thank you.
And then I'm going to show you 2 pages of this.
Okay. Thank you.
You could review that and look up once you've had a chance to review that.
Okay.
I'm sorry. I'm gonna-
Okay, you're away from the mic. No, I'm just telling him he's away from the mic, so it might be difficult for the court reporter to hear you. Could you hear him okay?
Yes.
Okay.
Okay. I think I got it.
Okay. Having refreshed your memory, was 1,000 micrograms of fentanyl. What, if any, order did he verbally give you for midazolam?
Looks like 4
Okay. And in what method were these to be given to Mr. Millett?
through an IV.
Through an IV push or through an IV bolus? Or through an IV bag?
Push.
Okay. And describe what that means to you, your understanding of that in 2017.
Yeah, draw it up in a syringe and administer it through an IV.
Do you recall the unit dosage that fentanyl was available to you in the ICU from the Pyxis machine?
100 microgram vials, so 2 mLs, 50 micrograms each.
Okay, so how many vials did you have to get out of the fentanyl to get the 1,000?
10.
And do you recall the unit dose of midazolam that was available to you in the ICU Pyxis machine?
I believe 2. So it was
how
1 milligram per cc, 2 milligram vials.
So how many vials of midazolam did you have to get out?
2.
And then how did you prepare these doses to be able to give them through an IV push?
Took a needle and a syringe, I drew them up, put them into the patient.
Okay. And where would you have drawn these up?
In the room?
Was the family present when you were drawing these up?
I'm not sure. I always gave family the option to stay for that. I never told them they could leave. I would be very upfront. I'll draw them up in front of them. I'll draw them up if they don't want to see. Most of the time, in my experience, I believe families stepped out just because there is the potential when you pull an endotracheal tube or an ET tube, you can have a laryngospasm, a bronchospasm, people could vomit, they could cough, secretions could come out. It could be very distressing. So people had the option to stay if they wanted to see that. But I drew these medications up in the room.
Okay. Do you recall, you said you believe there was a hydromorphine dose also ordered, given to you verbally by Dr. Husel for this procedure?
Yes.
And do you recall the dose of hydromorphine that you were asked to give?
I believe 2 milligrams.
Okay. And was this also at the same time as the fentanyl and midazolam?
Yes.
Okay. And how was that to be given to Mr. Millett?
IV push.
All right. So, in summary, the verbal order was 1,000 mics of fentanyl, 4 milligrams of midazolam, 2 milligrams of hydromorphine.
Yes.
Is that all?
On that MAR, it looks as though there was another 50 micrograms of fentanyl as well. That I don't remember, but to my knowledge, it was 1,004 and 2.
Okay. Did you ask for clarification from Dr. Husel when he gave you this verbal order?
Yeah, in fact, I called pharmacy as well.
Okay. Why did you ask for clarification from Dr. Husel when he gave you this verbal order?
Twofold. The first being that I just wanted to know where his head was at. Although a mentor to me and established, that doesn't mean that he's beyond. Sometimes, I would not be afraid to question anybody. But I sought the clarification because I wanted to kind of get a sense of, hey, where's your head at? Why are we doing it this way? Things like that, because I just wanted to get on the same wavelength as him to help my understanding.
All right. And you called pharmacy.
I did.
Now, this was a verbal order. Does that mean, how did you have to withdraw it out of the Pyxis machine on a verbal order?
I would have had to go and log in and pull the medication myself.
Would this been on override?
Yeah, I overrode using my own independent nursing judgment, believed it to be an emergency, and I thought I was justified in overriding said medication.
Okay. And while we're on the topic, based on your training and experience in the ICU at Mount Carmel West, how common were overrides?
In my experience,
Yes.
everybody did them.
Okay. Was this standard operating procedure in the ICU at Mount Carmel West, based on your experience?
For the limited time that I was on days, yes, and when I worked night shift, yes.
Okay. But you called pharmacy.
I did.
Why did you call pharmacy?
I called Greg White, and I told Greg White that, hey, we're going to do a palliative extubation on this patient. These are the medications he wants to give. I don't believe I had ever given that level of dosing before. So, and I just wanted to just tell pharmacy, hey, this is what we're going to be doing and this is the meds I'm going to be using. And then I told Greg that he could come up to the bedside and talk with us if he wanted.
What happened next?
So all I know is that Greg came onto the unit. I saw Greg present on the unit. I do not know if a conversation happened. I do not know anything after that other than I found Husel shortly thereafter. I said, hey, you know, are we good to go? Is this still what the goals of care are? And the answer was yes.
What happened next?
I gave the medication.
What happened next?
The patient's family was asked to be back patient's family, I don't remember if they were in the room or out of the room, I'm not sure, but patient's family spent time with the patient. Him being Dr. Husel and I sat nearby at the nurse's station to where we could be there if family needed anything.
All right. Now, we've heard from previous people that have been through this as professionals at Mount Carmel that you disconnect or black out the monitors in the room.
Yeah, it's basically a way to it's not shutting off, it is a way to pause all of the alarms in the room so it's not distressing to the family if they're praying or something like that. So they don't get to see anything, and that's only because we want them spending those last moments with their loved one. We don't want them watching the monitor. There are nurses who didn't, you didn't have to do that. That was a courtesy that we provided because we wanted that to be about their interaction and less about, okay, oh, it's flatlined, the patient is now passed. So we were able to see those outside of the unit, or not outside of the unit, outside the room, without the family having to hear or see all of that as well.
At that nurse's station, you've got a monitor up that's showing what's going on.
Yeah, there was a number of them around the unit.
Okay. So what happens next?
The patient died.
Do you recall how quickly the patient died or how long the patient lasted?
No.
Could you estimate in your mind how long it was?
Minutes.
Okay. What happens next?
We let the family spend time with their loved one. Some of them, do more prayers. Some of them do that. What happened next is the family said their goodbyes. I went in. I pulled out the remaining tubes and drains in the patient. I washed the patient. I cleaned the patient. I tried to give the patient the care that he deserved, and then I put him in a body bag and took him to the morgue.
Okay.
And I believe I enlisted the help of some of my other friends, co-workers as well, to help with that, just because it's a grown gentleman.
Sure. And before we move on from Mr. Millett, did you recall reviewing the pain score charting that he received during his stay at Mount Carmel on December 5th?
Yeah, I reviewed that.
And what were the previous pain scores prior to your entry as you gave the medicine?
0, or not entered.
All right. And what pain score, if any, did you give Mr. Millett as you administered those medications?
I believe I gave him a 10,
Okay.
and that is incorrect. And that is incorrect because I used something called a CPOT score. CPOT is the observational scale that you use when a patient is unable to communicate themselves. That scale goes from a 0 to an 8, whereas any other scale usually goes from 0 to 10. So I scored that trying to indicate the maximum amount of pain, and I'm not sure why I settled on 10. That could have just been a lapse in judgment on my practice.
What did you, looking back, using the CPOT scale, if you had that in your mind, CPOT only goes from 0 to 8, what would you have ranked Mr. Millett's pain at the time that you administered those pain medications?
Consistent with my charting, I would have given him an 8.
Okay, and why would you have given him an 8?
So I would have given him an 8 for a myriad of reasons. The first is what's going on with him. So he's had CPR. He has a tube in his mouth. He has, I believe, an A-line, so he had a tube in his groin or wrist. I don't remember which. He has a tube shoved in his penis. He has a tube that is in his neck. He has lactic acidosis. Lactic acidosis is something that if you go on a long run or you do an extensive workout, that pain you feel is because you restricted blood flow to your muscles, to your chest, if you were benching or something like that. He has a he has a lactic acidosis level, so that could, in my opinion, be painful. So I'm scoring it based on, and he's had a surgical procedure. I've scored that based on what is going on with him. His limb is now potentially rotting off, and I'm also anticipating a good deal of pain.
Okay, let's break that down a little bit.
Okay.
Just to revisit that, you said he had a tube shoved in his penis.
Yep.
Why did he have that?
It's a urinary catheter. When you are intubated and on life support, we like to measure urinary output because that's a good indication of how the kidneys are working. In this gentleman's case, Foley catheter, a urinary catheter was placed. His lab levels, his creatinine is a measure of kidney function, is elevated. Urine output is low. His kidneys have failed or are in the process of failing.
Yeah. But that term, quote, tube jammed into penis, that's not how you describe a Foley catheter, is it?
It depends. I mean, that was how it was put to the family.
By whom?
Dr. Husel said that.
Right. Those are Dr. Husel's words.
Yeah, and I seconded that information.
When you charted the previous 0 or didn't chart pain at all, while he is under your care as you came on the ship, did you give him any pain medication for any of the pain you felt he was in at that point?
I don't understand the question. I'm sorry.
Well, you say that it's not just based on anticipation of pulling the tube out and letting the dying process happen. Mm-hmm. You're saying all these other things that have happened to him.
Okay.
The Foley catheter, the arterial line, the chest compressions.
Right.
And when you say surgery, this isn't from December 5th. This is from a week or two before.
Objection leading.
Okay, I'm gonna let him clean it up. Do you understand the question?
I do.
Okay.
But in regards to the specific point about surgery, there's still surgical incisions,
Okay.
and those things tend to hurt afterward. But to that point, to your question, I don't think I gave him any pain medicine leading up to that point.
Okay. And so it wasn't just those things. You were also anticipating that this process is painful and unpleasant of dying, the process of dying.
Yes, dying in that way. You know, this is, in my opinion, I always made it a point, this is atypical from regular palliative care, in my opinion. Palliative care is somebody like a loved one who gradually declines over the course of days to weeks to whatever, right? It's more of like a plane landing, a gradual descent into death, whereas I liken what I believe I was going through and what the patient was going through to a helicopter. You know, he came in, admitted on the 5th, and died on the 5th. This wasn't a gradual decline into death. This was rapid clinical decompensation.
And he did die quickly after the tube had been pulled out and those medications.
And the vasopressors were stopped. Those tend to be they don't last very long once they're turned off or stopped.
All right. Let's move on to, Judge, it's 10:15. I'm going to transition to the next patient. Are we still good? I mean, I'm just letting you know I have a transition here, but I can keep going just fine.
Why don't we go till 10:30 and then we'll take a break?
Yes, sir. Let's go to May 28th of 2018. So that was in December of 17. So we are approximately 6+ months later.
That's correct.
All right. And so now your experience as an ICU nurse is night shift, Mount Carmel, 1.5 years plus at this point?
That's accurate.
All right. Have you been promoted to charge nurse at this point?
No, I never wanted to be a charge nurse.
Okay. Are you precepting anybody at this point?
I don't believe so, no.
All right. So, James Allen,
Okay.
tell us about coming into work, the first time you remember seeing James Allen.
Yeah, so James Allen, I came on to work. James Allen was placed in the CVICU. Mount Carmel had a mixed ICU, but there was another part just across the hall that had about 6 beds maybe where you could have an ICU patient. So he was in the cardiovascular ICU, although he was there for a medical-based issue. We used that because that's where the open room was. But yeah, I would have gotten a report much similar to how I described Mr. Milletti's case. So for Mr. Allen, I got report. It had been reported to me that he was admitted. He had an ejection. So one of the things that stood out up front is in his past medical history is something called an echocardiogram. That is a way to assess how well the heart functions as a pump. It fills, it pumps, it fills, it pumps. Every time that the heart pumps, a certain amount, a certain percentage of what it's filled with comes out. Normally, usually, a normal value is 60%, 65% maybe. His was 10 to 20%. So he's a very sick patient with COPD, and other coronary artery disease, coronary artery stenosis, vasculopath, like a peripheral vascular disease presentation. So that's the background that I get. I learned that he is admitted because he came in for a procedure. He was in endoscopy, so they took a scope down and they placed a stent in the bile duct to remove gallbladder sludge. I believe he had that twice. There was a complication which left him in the ICU. In the ICU, he was septic from that. And he was on vasopressors and undergoing care. He actually recovered from that and was transferred off of the ICU to a different part of the hospital. I don't remember where. Where I get involved is learning that, okay, secondary to all this information, he comes back to the ICU after rapid response took care of him, after having some trouble getting in contact with certain doctors. He was decompensating and came back to the ICU in what we call AFib with RVR, which is atrial fibrillation with rapid ventricular rate, which is a body's basically fight or flight mechanism trying to keep him alive because he's beginning to go septic. He's beginning to be infected. And I'm losing track right now, but there is a chance that he lost pulses. I don't remember if he coded or not, but I know that it wouldn't surprise me if you told me he did.
Okay, if the medical records reflect that he did have a code while he was there,
Yeah.
Would that confirm that that memory in your mind?
Yes.
Okay. Do you recall his age?
I believe he was in the 80s.
Yeah. Do you recall his weight and height?
He was a bigger guy, bigger than the first gentleman that we discussed. I believe he would be classified as being obese.
If the medical records reflect that he was 6 foot and about 188 pounds, would that be obese in your mind?
It depends. If you're using a BMI scale, it's very possible. But BMI would say that we're all obese, so.
All right. Well, if the medical records say he was 6 foot and 188 pounds, would that sound right in your memory?
Sure.
Okay. So he's a very sick gentleman. That's the report you get.
And I believe he's on vasopressors as well, and he's intubated. He, in the rapid response note that I was gotten report, he vomited, and he vomited what appeared to be blood. And the blood went into his lungs. So this is what I say, like if you've ever drank water and something's gone down the wrong pipe and you cough. Well, in this instance, blood from wherever, a GI bleed or something, gastrointestinal bleed, must have went down the wrong pipe and led him to a profound pneumonia. So that pneumonia progresses to lung destruction in the form of acute respiratory distress syndrome called ARDS or ARDS. So he is beyond sick as an ICU nurse.
And when it goes down the wrong tube like that, that's called aspirating?
Yeah, aspiration, yes.
All right. So had you treated him prior to May 28th?
I'm not sure.
Were you aware that he came in on May 24th? Does that sound right?
Yeah, it sounds right.
So 4-day hospital stay, man in his 80s, 6 foot, 188 pounds, all those problems you described. And you recall that part of your understanding of his condition was this endoscope to get rid of the sludge in his, and a stent being placed, but that having to be done a second time.
Yeah, there was a complication.
And it's thereafter that he's transferred up there because he has this episode of throwing up blood and aspiration.
Well, kind of, because not stenting that area, not opening up that area was what was giving him symptoms to have the need for said procedure. So you can go septic from that. So his first initial admission to the ICU, he was for septic shock secondary to the complications of his ERCP or his endoscopic procedure, recovered, had a setback, maybe the infection worsened, the aspiration infection took over, and then he came back to the ICU.
Okay. And when he came back to the ICU, do you recall whether or not he was intubated at that point?
Yeah, he coded, yeah. He would have had most of the things that the first patient we talked about. Usually that is a routine procedure to give people a catheter, an A-line, a central line, which is an IV typically in the neck or groin, and things of that nature. Fully catheter.
All right. So this is how he presents to you on May 28th.
And that's what I get, yeah, that's how he looks, and then of course that's what I get in report.
All right. So you're getting on your shift, you've got the report, what happens next? Do you know his code status?
I don't remember what his code status was.
If the medical record...
I'll permit the question, but you went from one question and transitioned to another, so you had a hanging question there. But he answered your tail end of it. Let's move on.
Is there anything I could show you which would refresh your recollection as to his code status?
I'm sure there is, yeah.
All right. Well, let's move on while I'm looking for that. So he is not, though, at this point in your memory, somebody that you're pulling the tube at as you come onto work. Is that right?
I don't understand.
He's not DNRCC.
I don't think so, but I would like to see to be sure. One
Okay.
thing that stood out to me, aside from his vasopressors, the adrenaline that he was getting, was his ventilatory settings. So he was, in a typical ARDS or acute respiratory distress fashion, he was requiring even more support than what usually goes on.
Okay.
So I do anesthesia, right? So most people who get intubated for procedures get, I'm sorry to go on a tangent, but I think it's important.
Well, we need to make sure that what you're testifying to is based on your understanding at the
Oh,
time.
100% I would know this, because
Okay.
this is something that I learned after, I said like about a year to a year and a half is when I felt comfortable, so I would have known this.
Okay.
Everybody in this room is breathing 21% oxygen. So out of all the gas and crap that makes up the air, 21% of it is oxygen. When you typically intubate a patient, or I intubate a patient for surgery, or even back then if you had to go on the ventilator for a couple days, you would usually get about 40% oxygen, which is about double, and 5 of pressure, otherwise known as PEEP. It's the amount of pressure in your lungs to keep them inflated. This gentleman was on 100% FiO2, so 5 times the maximum amount of oxygen we can give, and his pressure, which is normally 4 to 5, was 12. So just to keep his lungs inflated and pressurize air through was a chore in and of itself.
But you're able to do that, right?
Yeah.
All right. What about the pain that you're observing as you're treating him?
I'm not sure.
Do you recall him being in a lot of pain when you're treating him? He's on a lot of life support.
Yeah.
Tell us about what you recall, if anything, regarding the amount of pain he's in.
I'm not sure. I know that he took pain medication at home, but I'm not sure if I independently gave him a dose of medication.
Okay. So of all the things that you're treating him for, as he's your patient that night, the
Yeah.
ventilator settings that you've described, the myriad of medical conditions that he has and apparently is declining, pain is not one of those things that you recall having to treat him for.
Not that I recall.
Okay.
There was also, similar to the first patient, he also had an issue where he began to lose perfusion to his limbs. I believe that was also a leg. And much similar to the first, Dr. Husel called to the bedside and a vascular consult was placed. I'm sorry.
All right. Did that vascular consult happen to your memory?
I don't know. I don't think so.
All right.
I would imagine it did not.
Do you recall if this patient was on paralytics or not?
I'm not sure.
All right. Why would you give a patient on a ventilator paralytics?
It depends. The patients can overbreathe a vent. A vent can function in a way where it is going to deliver a set amount of air or oxygen every so often. You specify how often, and it's going to deliver that no matter what. Now you can overbreathe that vent, and you can do what's called fight the vent. So as the vent is pushing air in, you can be trying to exhale, and it can lead to basically issues where the patient is fighting the vent. So you could put somebody on a paralytic medication to take away that ability so you can let the ventilator do its role.
Judge, I'm going to object. Relevance, this patient wasn't given paralytics.
Okay, I'll let it stand as it is. I'll note the objection overruled.
Thank you. May I approach the witness?
You may.
Referring to joint exhibit. What joint exhibit are we on here, please? Mr. Allen is 8, right? Joint exhibit 8. Joint exhibit 8, showing the witness a progress note from that date regarding his code status. If you could review that progress note. Mr. Deemer, does that help refresh your memory?
Yes. I mean, I don't know. I'm trying to, maybe you can help me. How can I figure out when this,
Okay,
what's the
why don't we
date?
take a recess at this point in time, because it's time for a break. Okay, ladies and gentlemen, remember the admonition, 15 minutes. We'll get started at 15 till. Have a wonderful break. Have a good break, guys. Okay. Sir, you're under oath and you're also on the stand right now. We're going to take 15 minutes. Relax. You can't talk about your testimony. You can answer factual questions for them. But if anybody asks you how you're testifying or why you're testifying a certain way, it's improper.
Okay?
Yeah, I won't say anything.
Go ahead and relax, and get off.
That this was court and then later that evening at 11. So I was trying to establish, and he just can't remember, so I was just trying to refresh his memory.
Mr.
I
Zion,
understand the
anything for the
question.
record?
You want me present to?
But we'll figure it out.
For the record, anything?
Not from the record, Your Honor.
Mr. Baez?
No, sir.
Okay, you were talking into the jury, let's avoid it,
Yes, sir.
okay? And
Yes,
I
sir.
understand handling the records over here that you're doing that, but when you get away from the mic, it's tough to pick you up.
Yes, sir.
Just to let you know. Okay, we're on break.
I'm trying to figure out when this note was in the record.
Ron!
Doesn't it feel about 15 minutes? Sometimes I like that.